and tasks, and this is going to be a reality, and this is going to be a way to go. In University of Pittsburgh, you also have first tryouts with robotic humanoid robots which do assistance during the surgery. So I think this is going to be a major game changer in the time to come. And there will probably not be a long time before we see situations like this. This video was made in Bangkok during the Global Spine Congress. It is now just a funny joke and a gag, but it is. I think we are going there faster than we think. So what is a robot? It's a programmable powered manipulator with artificial sensing, which can assist in variety of surgical tasks. The first application was using brain biopsies in 1980, and expansion of robots in neurosurgery so far was limited by narrow surgical corridors and delicate neurovascular structures. So this is the first robot from the 80s, Puma 200. You will see that the robots which we use nowadays are actually based on the same principle. So there are three types of robots: supervisory controlled robotic systems, which are very rare in neurosurgery. You have robotic telesurgical systems, and I'm going to talk today on shared control systems, where robot and surgeon remain jointly in control, where the surgeon remains in control of the procedure, where the robot provides steady hand manipulation of the instrument. So we actually have a cobot surgery, another real robot surgery, because robot surgery would be a surgery where robot does surgery from the beginning to the end. This is a cobot surgery where robot assists with a distinct but critical and difficult task of the operation. And it is possible that in the future it may be necessary for not just one but several robots to assist in completing neurosurgical procedures. So current FDA and EMA approved use for robotics in spine surgery is only for assisted pedicle screw placement, which is very important due to high misplacement rates and all problems which can go from that when you look at the literature: neurological deficits, CSF leak, vascular injury. But there are many off-label uses for robotic guided placement of cages, and for lately robotic laminectomies. There are some case reports and case studies on use of robotic laminectomies on cadavers, and several days ago we had first clinical reports on this technique. So the first robotic system of all times, which was FDA approved, was some 20 years ago, Mazor, in 2004. And now you have a variety of robotic systems from all over the world: South Korea, Japan, China, Germany, United States. Pros of robotics in spine surgery are facilitation of MIS surgery, easier high pedicle screw placement accuracy, according to systematic reviews, even more than navigation, 99.5% versus 95.1%, decrease in revision and complication rates, and applications with ORM and ICT. Cons are prolonged operative time, registration, installation issues, and of course, very high cost. The operative time is usually longer in open versus the percutaneous group, and in this single center experience, robot screw time was similar between the cohorts. The best studies to explore these differences are single surgeon studies, because I think they show more objectively what is actually going on. And we have nowadays age of active robots for pedicle screw placement. This is our initial experience, which we published. We are now publishing our first case series. And there are several ways of how to deem if the robotic guided surgery was successful or not. You have a pre-planned screw trajectory and you place the screw. If you have a very small deviation of the placed screw versus the planned screw, then the robot has done its job. This is our robot, which we use, Circ from BrainLab. This is our intraoperative setting. You have a patient which is positioned on the table. You have an ICT and the robotic arm, which is then placed on the left side. And these are the operative steps when performing a robotic-guided spine surgery for pedicle screw implantation. You have preoperative imaging, and according to that preoperative imaging, you perform a screw planning. Then in percutaneous cases, you do a small incision and put a reference array on the spinal process and do an intraoperative image. In open cases, you expose all of the field where you want to place screws, then put the reference array on the spinal process and then do the image. Following the imaging, you do the automatic registration of the patient, fuse preoperative and intraoperative imaging, and review the pre-planned trajectories. What we do is then we use the robot to insert the K-wires, which is followed by fluoroscopy or navigated assisted implantation of pedicle screws. So the patient lies in an MRI and in CT on his back, but during the surgery, usually on his belly. And when you perform the scans, they are of course different because of the flexibility of the spine. And you have a possibility to do rigid and elastic or nonlinear fusion of the spine. And this is very important, and to check the fusion accuracy, and then to check the pre-planned screw trajectories on the intraoperative image, because if the fusion is not good, which is usually the case if you have a very long construct, and usually the case if you have the cervical spine, then you ought to correct your screw trajectories according to the intraoperative image. New softwares allow you also for deep learning algorithms, machine learning, and AI modules, which enable the system to recognize the vertebrae. You then just mark the vertebrae where you want to place the screws. And for deformity correction, there are some AI-based softwares which allow surgeons to plan deformity correction, where you just put what you want to achieve, and the AI-based modules give you an example of where should you do your osteotomies, where should you do your PCOs, and where should you put the screws. So there is a very, very high and rapid development in this particular area. So this is how the screw planning then looks like. The system gives you a proposition how the screw should be, and you should always correct that proposition usually. And you can adjust the screw length and screw diameter. And then you can also produce images like this, which show then actually very intuitively in three-dimensional way how the construct looks. So the steps are: you put the robotic arm over the projection of the screw trajectory where you want to place the screw. The robotic arm aligns automatically according to the trajectory screws. You go then with a dilator and with a trocar directly on the entry point of the pedicle screw. You drill the channel with a drill guide, put the K-wire, and then over that K-wire you put a screw which is then previously navigated. And this is how it looks during the surgery. So this is one percutaneous case where we actually do not do the small lateral incisions, but we do the one big midline incision and then do not open the fascia. And this is how these constructs then look. So until November 2023, we had 76 patients. In the meantime, there are 92 patients which were operated with circle robotic alignment for spine surgery, and we did not have any screw malformation since, screw misplacement since. So we have implanted some 650 screws and had only 8 screws which were revised during the same procedure. Now these numbers have changed a bit, but plus minus we have a total circ time or total time of use of robot around half an hour. So you need a totally half an hour, mean time half an hour, so 20 to 40 minutes to place all K-wires. And to place one K-wire correctly, these are the November data, it was like 4 minutes 30, but now this number is less. It is around 3 minutes 50. So accuracy in robotics depends on image quality and accuracy of image data, accuracy of planned trajectories. These are smart AI-based planning softwares. Registration method, automatic registration with intraoperative imaging is the best. Accuracy of tracked instruments, clinical workflow matters. It's very important to note where to place the reference array, how much pressure do you apply to vertebra, that you have a haptic feedback as control, tidal volume of the patient. We do all the ICTs in apnea, and you always have to think of these breathing artifacts. We always put all the K wires first and then the screws. Why? Because if you put a K wire and then you put a screws, there is a lot of manipulation of the surgical field. With that manipulation, there are micro movements of reference array, which then can make a big difference when you come to the last screws which you want to implant. The robot needs to be accurate where it matters without being over-engineered to avoid unnecessary and time-consuming workflow steps in the OR. And what is very important is to have a technically equipped person which is in OR with you the whole time, or which you can reach, which is in the same institution, which can help you with all the technology. This is the setting, and I will just show shortly. This video cannot be. I'm sorry, I will try to put it later. And these are some clinical cases. This is the intraoperative imaging registration accuracy check. And these are the instruments which we then use for implantation. And these instruments are tracked all the time. This is the screw trajectory. And this is what the surgeon sees on his displays the whole time. And when you put the screw, you can also check the navigation accuracy on the screw, and you have the intraoperative CT, which shows you the immediate control. Now, even with this perfect technology, you have cases like this. This is published where we have put a very wrong medial screw, probably due to movement of the reference array. But then again, if you have the intraoperative imaging, then you always have a possibility to do the control and to correct the screw placement. And this is what we are now doing nowadays. So this is double control. You drill with using robot a hole with a drill guide, and then you put to navigate the screw. Some people also refer to this as augmented reality, but I would say in that context that augmented reality for screw implantation is that what we heard in the first talk today, and this is just a simple navigation. So as for the screw misplacement, some risks for rate, low entry point, inaccuracy, registration, movement of the registration array, skiving, usually in the context of osteosporosis, abnormally steep slope, obesity, and congenital scoliosis. And we are big fans of segmentation. You have the preoperative screw trajectory, then you place the screw, in this case, laterally. You can do the segmentation of the screw, and then you can know more intuitively where does it lie wrong compared to the where you want to put it, and then you can correct it according the way you want. And this image shows very nicely that it is possible to completely follow the plan which you have set. This is not always possible. You know, a lot of screws do not follow the plan, but are actually clinically acceptable, and we do not revise them. And this is also the best indication for robotic guided pedicle screw implantation. It is the thoracic spine, actually. So robotics enables to put screws with great screw diameter and length compared with surgical navigation alone with similarly high accuracy. Robotic systems are unable to decompress, decorticate, or contour or place rod. Unable is not a good term. They are able to do it, but not able to do it that safely to go into the clinical practice. But I think we are going there with giant steps ahead. These are some other applications of robots: to put iliac screws, to put cage, to do percutaneous endoscopic transforaminal discectomies. And future of robotics would be that, although they currently act as simple guides to help position tool for ideal position or trajectory, I think restriction of working hours is going to push this technology even more forward, that the less trained spine surgeon will be expected to do more and more, and the robotics would allow for increased safety, development of robotic suits, safer and more thorough decompressions, incorporation of artificial intelligence, MRI-based navigation, which could enable soft tissue handling, cage implantations, and use for no-fly zones around protective structures such as dura, robotic laminectomies, gloves with motion sensor, and automatization of simple procedures such as wound proof. So thank you very much. That would be from me today.
Mirza, great presentations. Thank you so much for
Thank you.
your contribution. I think we're gonna leave the questions for the ends. And in the meantime, I will present Professor Federico Nicolosi from Italy. He is to follow after you now. Professor Nicolosi is the founder and CEO of Upsurgeon Company. Many of you probably have heard, many of you might have not, but this is a company that's producing very realistic cadavers, artificial cadavers, artificial models, which can be used for which can be used for training. So I can't wait to see what he will present now.
Thank you so much, Nikolai. Thank you so much. Do you hear me?
Yes, very well. Thank you.
Thank you for having me, for organizing this fantastic meeting, Nikolai, Misra. I will share my screen on a
Thank you.
present. So.
Michael, are you on? Let me see if I can find you.
But he's a
Hi, good afternoon.
Hello, hi. So we have another Michael, but thank you so much. That's Professor Michael Fellings. Thank you so much for joining us today.
Pleasure.
Yeah. So Imat, do you wanna start the presentations?
Sure.
Michael?
I have two video files that you could show.
Yes. So we have them downloaded and they are working. Thank you
Perfect.
so much for joining us and for taking part of your valuable time to be with us and to teach us.
Pleasure. And I'm happy to take questions after the video presentation. Okay, very good.
Okay, Imat, are you ready? Right. So maybe I can do that then. Let me see. Okay, so which one you prefer, Michael?
We'll start. Yeah, I think we'll start with the spinal cord injury guidelines, and then we'll go to the cervical myelopathy presentation.
Perfect. Okay.
Perfect. Thank you. Perfect. Hello, I'm Michael Fellings from the University of Toronto, and it's a Hello, I'm Michael Fellings from the University of Toronto, and it's a pleasure to be part of this spine update, which is a part of the INTS 2024 meeting here in Cambridge, and is also associated with the World Federation of Neurosurgeons. It's my pleasure to present to you the updated guidelines for the management of acute spinal cord injury, which were co-sponsored by AO Spine and the Praxis Network. I have no relevant commercial disclosures, but I do wish to acknowledge the organizers of today's course, and in particular, Nicolai, Mirza, and Francesco. Many thanks for putting this together. I also wish to acknowledge the wonderful team of collaborators that were involved in putting these guidelines together, and these are listed on this slide. And I particularly want to acknowledge my co-chair, Dr. Brian Kwan from the University of British Columbia. In 2017, we issued our initial AO Spine guideline for traumatic spinal cord injury. These were focused on the role and timing of decompression, the efficacy safety of methylprednisolone, the efficacy safety of thromboprophylaxis, the impact of baseline magnetic resonance imaging, and the type and timing of rehabilitation. Of note, these guidelines have been externally evaluated using a technique referred to as the appraisal of guidelines for research and evaluation, or the AGREE-2 instrument. And using this external validation, the 2017 guidelines were actually the highest rated guidelines in the field of spine surgery and acute spinal cord injury. But guidelines are living documents and require updating. And in the current issue of the updated guidelines, we've tackled three topics. The first is an update from the 2017 AO Spine guideline related to the role and timing of surgical decompression for acute spinal cord injury. The second topic related to the optimal hemodynamic management of acute spinal cord injury essentially builds on the 2013 AANS-CNS guidelines. And the third topic is a new topic, and this has to do with the prevention, diagnosis, and management of intraoperative spinal cord injury. These guidelines were generated using the state-of-the-art GRADE methodology, which involves the collation of scientific evidence using high-quality systematic reviews, and then this is filtered through a guidelines development group based on consensus meetings. The systematic reviews were done by an independent methodology team led by Andrea Skelly of Aggregate Analytics. And then the guidelines development consensus meetings were facilitated by Zoom to include very broad international participation, including people from multiple disciplines, as well as individuals with lived experience. And then one uses what's referred to as an evidence to decision framework to craft these guidelines. So in terms of the role and timing of surgical decompression, we were able to evaluate 21 studies. This was in contrast to 5 studies which informed the 2017 guidelines. And this is the systematic review publication in the Global Spine Journal in March of this year. This is the consort diagram. 21 studies met inclusion criteria. 6 studies were included in the prior review, and there were 15 new studies. One of the key studies was one that we were involved in putting together. And this was a paper published in Lancet Neurology, which included 1,500 patients from the STASCUS, NACT, NASCUS 3, and SIGEN prospective studies. And essentially, this was a pooled data, 1,020 patients with delayed surgery and 528 with early surgical intervention. This is one of the tables from that paper highlighting that patients undergoing early surgical intervention within 24 hours after injury had on average a 4-point motor score improvement. This study and a number of other studies have informed the subsequent meta-analyses. And here I'll present the synopsis of the evidence. So here in these forest plots is outlined the recovery of 2 or more grades of surgery, or rather 2 or more grades of motor recovery with early surgical intervention. And here we see that at 6 months and a 12-month follow-up, there is a highly statistically significant improvement in the odds ratio of patients having a major degree of neurologic recovery with early surgical intervention within 24 hours. In addition, we confirmed the results of our Lancet Neurology article showing that on average there's a 4.5 improvement in motor scores, which is also statistically significant. And then importantly, there were no increased complications, no increased mortality with early surgical intervention. And in fact, there was a reduction in these complications, which just narrowly missed statistical significance. So early surgical intervention can be undertaken safely by experienced teams. So here are the recommendations. And we now have a strong recommendation based on moderate quality evidence that early surgery be offered as a preferred option for adult patients with acute spinal cord injury, regardless of level. Now, the caveat is that these patients need to be medically stable. Now, we were unable, however, to come up with clear recommendations on the role of ultra-early surgery because of small sample sizes, variable definitions in terms of what constituted ultra-early surgery, and inconsistency of the evidence. One of the lines of evidence that came out after we'd undertaken the systematic review, but which was included in our guidelines documents, was this important study from Europe called the SkyPoem study by Hoffman et al. And in this study, the authors compared ultra-early surgery, less than 12 hours, versus a combination of early surgery and delayed surgery. But most patients were operated on within 24 hours. The unadjusted analysis did suggest improved recovery in the lower extremity motor scores with early surgery that just missed statistical significance. But there were significant baseline differences in the ultra-early and early-late groups, and quite a high rate of loss to follow-up. So I would say that this study points in the right direction in terms of potential role for ultra-early surgery, but further work is needed. This work by Bijan Arabi also highlights that technique is important, and the extent of decompression likely matters, as well as the timing of intervention. And an example of a surgical technique that's being explored is the work of Marius Papadopoulos, who's undertaking a randomized controlled trial to assess the role of expanded style enduroplasty in traumatic spinal cord injury. So what about hemodynamic management? We recognize that this is an important principle. This is a photograph of Nathan Evenew, who is on faculty at the University of Calgary. And essentially, there was a systematic review that Nathan and others undertook, suggesting that there was very low quality evidence related to the role of MAP support on neurologic recovery to acute traumatic spinal cord injury. So we undertook an update of this systematic review, and there were a total of 28 publications, including 1 RCT, 27 observational studies that were assessed. Now, the concept of spinal cord perfusion pressure is emerging. The idea, analogous to the management of traumatic brain injury, where we need to consider the mean arterial pressure and the pedicle pressures to derive a spinal cord perfusion pressure. And this is work, again, that is being assessed prospectively by Marius Papadopoulos' group. However, what is the current state of the evidence? And the long story short is that to date, the evidence is unfortunately premature. It's of a very low nature of quality. It does not really allow us to make conclusions related to the role of assessment of spinal cord perfusion pressure. Now, in terms of the mean arterial pressure, there is evidence. Again, this is of a relatively low nature, and there's also relative uncertainty in terms of the best vasopressor to use. So based on this, kind of the bottom line is, according to very low quality evidence, while the effect of MAP support and neurologic recovery is uncertain, and while we're unable to discern specific recommendations around spinal cord perfusion pressure, we would largely agree with the recommendations made in 2013 by the AANS and CNS, but with some modifications. And so we have broadened the MAP targets to shoot for from 85 to 90, with a more practical range of 75 to 80 at the lower end, 90 to 95 on the upper end. And we've also relaxed the requirement for 7 days of monitoring in an intensive care unit to around 3 to 7 days based on the judgment by the treating team. And the choice of vasopressor should be left to the clinician, because the evidence really is not there to say that one is better or the other. And perhaps in the Q&A period, I can discuss what our own protocols are in Toronto. And then finally is the topic of intraoperative spinal cord injury. And here are 2 high-risk patients, one with a complex thoracolumbar deformity, another patient with ossification of posterior longitudinal ligament and severe compression of the cervical cord. So we sought to define what improper spinal cord injury is, to delineate the frequency, risk factors for this, to try to inform clinical decision-making. We also did a detailed assessment of the potential role of intraoperative neuromonitoring to detect changes. We then tried to define through scoping review what potential management strategy for intraoperative spinal cord injury might look like. And then finally, we came up with a care pathway for this condition. We defined intraoperative spinal cord injury as a new or worsening neurologic deficit attributable to spinal cord dysfunction during spine surgery that is diagnosed intraoperatively by neurophysiologic monitoring and/or a wake-up test, or immediately post-operatively based on clinical assessment. And here in this table, based on the scoping review, we have suggested potential high-risk patients for intraoperative spinal cord injury. Now, this is by no way conclusive, and obviously this does require a judgment from the treating team, but these are some suggested diagnoses to consider. For patients with certain types of deformities, rigid thoracic curve with high deformity angular ratio is at higher risk, revision congenital deformity. Then lesions which are associated with compression of the cord, such as OPLL, certain types of fractures, including ankylosing spondylitis, certain high-risk tumors such as intramedullary tumors are thought to be at quite high risk for potential intraoperative spinal cord injury. We undertook quite a detailed meta-analysis of multimodality neuromonitoring, and essentially the combination of motor somatosensory evoked potential plus or minus EMG has a sensitivity of 91% and a specificity of 95%. So quite good from a clinical perspective. And here again, we have validated this using a random effects model. So in terms of the summary of recommendations, for the first key question of whether we would recommend intraoperative neurophysiologic monitoring for patients undergoing spine surgery deemed to be high risk, there is a recommendation, which was a strong recommendation based on a relatively low quality evidence that this be undertaken. We then essentially adapted a care pathway and protocols from Vitali's article. This relates to an intraoperative checklist for how to manage changes in intraoperative neuromonitoring. Surgical factors can be considered neurophysiologic and technical factors, and anesthetic and systemic factors. So one should, for example, take an intraoperative pause, eliminate any sources of external distraction, and then try to consider what factors were related to the changes in intraoperative neuromonitoring, perhaps reversing these, for example, decreasing and removing contraction. From the neurophysiologic perspective, important to check the status of the anesthetic agents and also to rule out any technical factors. And from anesthetic and systemic factors, assessment of the anesthetic depth, optimization of blood pressure, and then other considerations, for example, consideration of the use of intravenous steroids or other medications such as riluzole. So the second recommendation is, should we recommend that patients at high risk for intraoperative spinal cord injury be proactively identified, and that after identification of such patients, the multidisciplinary team discussions should be undertaken to manage patients, and that intraoperative protocol, including the use of intraoperative neuromonitoring, be implemented? And the answer is yes. It is recommended that such protocols be developed and applied. Now, it needs to be acknowledged that this is still a weak recommendation, largely because of the lack of high-quality prospective data. Based on this, we would propose the following AO Spine Praxis Care Pathway, which we have published in the Global Spine Journal. This involves the initial clinical assessment, deeming if the patient is at high risk, preoperative planning, including multidisciplinary team discussions, surgical and anesthetic planning, for example, the identification and maintenance of MAP targets, intraoperative management, and then refer to the modification of the Vitali care pathway, and then postoperative management, so having a monitored bed, obtaining imaging, and so on. So this is a brief synopsis of the updated guideline for the management of acute spinal cord injury. This was published in March of 2024 in the Global Spine Journal.